For section 3, we're doing what is the system or workflow that you're trying to create, improve, or solve. My response was to encourage the providers to promote or prescribe tobacco cessation medication for patients who are identified as residents and who smoke by delineating an efficient and effective communication system. So section 2 was to describe how it is currently working and to include our details relevant to our case presentation. Primarily, I have used email to notify the providers of the residents coming from Parkview, which is our host site. Sometimes, though, this can take several weeks, actually, for them to either read or reply to those emails. Usually, when you call into providers' lines, most of them have it set up to where you go straight to the front desk or you're in the queue. And if they're in there with a patient, it's just not the quickest and most effective way to contact them. So due to the volume of patients on their schedules, they're with the patients most of the days. In addition to previous methods, we've also provided hard copies of the grant, the summary updates, for which we're followed up by verbal updates. And we've done this in our provider meetings just to kind of remind them of things, as well as the medication assistance. And I know that for the briefly describe your vision of what it will look like when it is working well, with clear and concise information provided to the providers, we can develop a better communication process with the providers to ensure that residents who are patients are being informed and or prescribed medication, thus creating an increase in the overall amount of former smokers. The next section is, have there been any recent changes less than 6 months made to this system or workflow, and to describe those changes when they were made and impact or successes and challenges. So in June, we issued out an I Will Quit card to the residents, and if you were a Hope Health patient, it was your responsibility to come into your visit to hand over your I Will Quit card to your provider. Well, you would actually hand it over to your nurse first, who would ask you to the tobacco cessation questions, and then the nurse would sign off on it and then leave it in the room for when the provider comes in, kind of like, here, the patient's here, they want to quit smoking, or they're here to be examined as a smoker, who is also a resident at the housing authority. And then the provider would go to that next step if the patient was interested in quitting, providing any interventions, and if not, then the provider would also document that as well. So the doctor would sign off on it, leave it, and then those cards would be sent to me, which I would also incentivize the patient for being responsible enough to take their card to remind their provider that they are with the grant project, and it also kind of helps the provider to acknowledge that this is someone who is not only a patient and a resident, but a part of this this project that we're working on. Along with this, residents, what data, quantitative or qualitative, do you have to augment your observations? And during my monthly reviews of my patient charts, I focus on each patient's medications, and I kind of compare them to the approved FDA medication list for those who want to quit smoking. There are 14 residents who smoke. 9 are patients of Hope Health out of that 14, and 0 of these Hope Health patients are prescribed tobacco cessation medication, and that's where we kind of are looking for a little bit of advice, information to kind of help close that gap up between patients receiving medication for quitting smoking.
Great, thanks, Celeste. This is super interesting, and I think a common challenge, so I bet we'll have a lot to talk about. I have one clarifying question, and then I'm going to turn it over to the group, so get your questions ready. Celeste, can you just talk us through your current workflow of how patients are assessed for tobacco use, and then what happens from there, and kind of what you're doing already with your patients?
Okay, so I don't actually work in the clinical area. But as far as what I have learned, they come in and it's just, I don't know. Oh, never mind. Okay, so patients will come into their visit to see the provider. Once in the room, they go through all their, all their history and medical history is updated, and in the process they come to the tobacco control question, where they just ask them, do you smoke, or are you a current smoker or whatnot, and based on that response will lead them into the tobacco cessation. They're asked several questions on, are you a current smoker, are you a former smoker, have you ever smoked, do you use any tobacco products other than cigarettes, and the list could go on and on. Just depends on what the patient's answer is, which we are also updating that smart form, which will hopefully be updated by the end of December. Along with that, then the provider will come in and go, we created this order set, which was actually created by Dr. Hannah, who is in the room with us now, which is kind of like a one little place, a central place for the provider to be able to go in and kind of document anything that has to do with the smoking cessation, whether it's interventions or referrals out, or a selection of medication. The only thing is we don't see as many providers prescribing medication for patients who are quitting. Now, we will see referrals, but we're also trying to work with our patients who are residents versus non-residents, that can get a kind of somewhat of a help with their medication cost if it comes down to it, and it will help them to stop smoking. But so far, none of our residents are using medication to help them quit smoking.
Great. Thank you. Thanks for walking us through that. Go ahead and interrupt somebody. Okay. Any other clarifying questions from the group?
Yeah, this is Frank. Celeste, why are you relying on prescriptions for the cessation medications when the 3 most popular and effective ones are over the counter? They don't need a prescription. Really, the only one right now that needs a prescription that's used very often is Chantix. Is this a requirement of your grant?
Say that again?
Is getting a prescription a requirement of your grant?
I don't think so. I think our thing is, though, out of all the processes of intervention that we could see to potentially help the residents to quit smoking, one of them that we saw that we were having absolutely no activity on was the medication for quitting smoking, where you can't track it if it's not going through our pharmacy, if it's not on the FDA-approved medication list. But as far as, over-the-counter stuff, we can't track that. But for what we can track, we just can't see anything.
Well, and to clarify, even though nicotine replacement therapy is over-the-counter, to track it in our EHR, you would still have to enter it as a prescription, documenting that the individual is on that agent. You couldn't just free text that.
Could you just have the pharmacist do that? Could you refer the patient to your pharmacy and then just have them enter that they recommended the patch and this is what they got?
Yeah, but
it wouldn't be nearly as accurate as in our EMR system.
Right.
It wouldn't be nearly as accurate as tracking it in our EMR system.
I'm just wondering if there's someone else that you can assign this role to, because as Steve will attest to, and anybody's doing this a long time, physicians just have a terrible record of doing this because they simply don't have the time during a regular session with a patient. So if you could get someone else to be responsible for this and enter the data, I think you would find a much higher usage rate and a much higher cessation rate. Even if you're referring to the quit line, they would track that for you too, I would think. You have some record at least through them. If you made a referral and then did it through that, you're an e-referral or a fax referral, then you're at least getting you're back, as Linda has told us many times, from the quit line. So that would help you track it a bit.
That's true for all statements. I think the other part of the equation,
Okay, hold on 1 second. Go ahead, Stephen.
The other part of the equation is by running it through the prescription process with our pharmacy, we're able to benefit the patient financially.
Mm-hmm.
Yeah.
This is,
we understand it.
oh,
Yep.
sorry.
Go ahead.
I was just going to add in the quit line most of them are only able to give 2 weeks of NRT. Only 3 state quit lines provide any level of prescription medication for tobacco cessation. So, one other benefit of having the prescription done at the clinic itself is you can prescribe a full course of medication. And for those who are Medicaid enrolled, hopefully there's no out-of-pocket for them for that. And as was mentioned, I think in the chat, most people enrolled in Medicaid are not able to get coverage, even for over-the-counter medications, unless they have a prescription. And so the prescription, I think, is a good idea at the clinic level for a number of reasons. That it's covered, it might reduce the barrier of having to pay out of pocket, and they could get a full course, 8 to 12 weeks, instead of just 2 weeks from the quit line. So I just wanted to mention that.
This is Steve.
Hey, this is Helen.
Excuse me?
Go ahead, Steve. This is Helen from South Carolina. I just wanted to give some input about our coverage for NRT for South Carolina.
Go ahead.
Okay, thanks, Steve. This is Helen with the Department of Health, and we're partnering for the South Carolina team. We do track this in 2 ways. Hope Health has what they have deemed sort of a one-stop shop shopping, where they see the client and then they can also refer them immediately to their in-house pharmacy program, where they are covering the proven effective NRT. And I believe, and someone from Hope Health chime in on this, it's free for those participants in the program, especially if they're Medicaid. And then in South Carolina, for our quit line, we also track any of those participants or clients who are going through the quit line. We do have 7 approved NRT products, and for Medicaid, they are all paid for. We did do that update back in 2018. So if they are a Medicaid recipient, the NRT is paid for in South Carolina.
That's very helpful. One other thought is that it sounds like you could use an advocate at Hope Health. And it may be worth trying to find someone who's in the clerical staff, maybe even do an in-person meeting so that they can just flag the patient's chart or do something else that's a reminder to get them a prescription.
Celeste, another thought is, could you get your Hope Health, like your medical director or somebody up high, to create a standing order so that it's already prescribed? They're doing that here in Pennsylvania with the opioid medications. There's just a standing order. If you're on medical assistance and you need it, you get it. So I know some states are looking into that idea. So it then takes it away from the physician who's seeing the patient, and it just can be done.
Hi, this is Amy Score with the University of Wisconsin. Similar to what Frank just shared too, with standing orders or some other way to offload that from the providers. So those who are rooming the patients, many times we have the roomers, the MAs, the nurses, being able to tee that conversation up and even getting the medication set and prescribed, and then just having the provider sign off on that. So the MAs, those roomers, are really the ones providing that intervention, doing all of the heavy lifting with the screening and dosing, and then the providers really just need to sign. So that might make things a little bit more streamlined and efficient. And then also, if there's some way like someone mentioned, to flag those patients who smoke or who are the residents. If that's like a best practice advisory, so you can make possibly a smokers registry based on their address or living situation, and then that can kind of bring up that best practice advisory within the EHR to kind of target those certain patients and make sure that they're receiving that intervention. So some way to flag those patients or utilize some of the tools within the EHR to make that more efficient to target those particular patients.
Great, thanks, Amy. Celeste, the standing orders thing, we can follow up with you offline after this and with the group around some more ideas on the standing orders and how to, I think I hear some of the issue is that having a prescription, whether it's for an over-the-counter medicine or prescription medicine that requires a prescription, it's how you're tracking how your patients are having access to the cessation services. And there's some ways I think that we can help with that. So Becky and I and Kim and Beth will follow up with you after and see if we can give you some more resources on that.